My name's Hi Ron. My name's Rohit Chaturvedi, and I'm pleased to present to you this presentation from Snore to Score, supported by the Good Sleep Company. And what we're hoping to do is provide you with a practical guide to screening, testing, and treating your sleep apnea patients in a primary care setting. So, just to let you know a little bit about me and who I am, my name's Rohit Chaturvedi. I go as Chats the Dentist on Instagram. And basically, I'm a primary qualified medic, and I graduated from Nottingham in 2006. And during that time in my initial years, I actually worked in multiple medical and surgical jobs. And one of those jobs, funny enough, was respiratory medicine, where one of my roles was managing patients with obstructive sleep issues and COPD using non-invasive positive pressure ventilation. And I would manage in their acute phase of illness those settings in a respiratory high dependence unit. Um, I went on to do a lot of surgical training and was progressing in a career in neurology before I decided to take a complete U-turn and do dentistry. But I got my membership to the Royal College of Surgeons in Glasgow in 2010, did a 3-year dental degree conversion from King's College London and finished in 2013, and then became a member of the Faculty of Dentists at the Royal College of Surgeons Ireland in 2014. Shortly after, I moved to Australia, where I worked in a corporate practice for 10 years. And this is where I kind of grew a lot as a practitioner. And I started going down the line of clear aligners. And in that time, I have gone to a postgraduate diploma, a Master of Science in clear aligner orthodontics. And that's pushed me to become a clinical advisor for Invisalign in the APAC region, as well as one of their trainers and key opinion leaders. And I strongly believe in scanning our patients using 3D planning and diagnostics, but also considering breathing when it comes to providing orthodontic treatment as well as restorative, because it has a profound effect on our ability to provide successful, long-lasting results. And this is something that we're going to talk about during the course of it, and the importance of understanding and diagnosing these kind of things at the start of our assessments of patients. I've also held roles as a clinical advisor for a large national Australian corporate dental group. And currently I'm in week 13 of being a principal dentist and practice owner of Roanco Dental, which is my current clinic, my start clinic. I like to teach. I speak for several education companies as well as Invisalign and dental product companies. I also like to collect urban and contemporary art and compete in world beard and mustache competitions. Now, the best I've ever done is 8th in the world in Austin, Texas, and you can see probably from the photo on the side when it's all creamed, it looks fantastic. Right now, it's here; it's just hidden in the beard. I try to hide my chin as well a little bit. Okay. So look, we want to talk about managing OSA in the dental practice. And what we're going to try and talk to is give you a very practical guide. We're not going to go into too deep into the complexities and nuances and overcomplicate things. We want to talk about what we can achieve as general dental practitioners in a real life, everyday setting. And one of the ways in which I do this is by leveraging the Good Sleep Test and the Hush Pro Vera. And I'll talk to you about why I chose to go down that line and why this is a product I'm quite passionate about and how it really helps. And I think in doing that, I'll also be sharing with you my journey from learning about patients with OSA and sleep disorder breathing, as well as the different appliances and my own personal journey of why I've decided to go down the line of a nylon mandibular advancement device, but particularly the Hushed Pro. So we're going to start with an introduction. We're going to talk about how you can start screening your patients for OSA in practice. And this starts the minute they walk in the door, really. And you probably are already doing this in real life practice, but you don't maybe realize that you're doing this, but you're just not picking up on the cues. And then it's where do we take those cues? Like, do we test everyone? Do we test some of them? Do we just screen first? So we'll talk about screening and testing, and then we'll talk about how we treat. And this will be everything from offering them the options and where they can go with this and how we progress down that pathway. And then we'll lead into a Q&A summary where I think Joel from the Good Sleep Company will also join us to answer your questions and concerns that you may have. So first of all, like, what is sleep apnea? What is obstructive sleep apnea? Okay, well, I think most of you will probably already know this, but it's basically just repetitive upper airway collapse during sleep. So what happens when we fall asleep? Well, when we fall asleep and we're unconscious, we lose muscular tone. And our soft air and our airways, upper respiratory tract will start to collapse. So that all the soft tissue starts to collapse. And this can obtund the airway, and also the tongue and soft tissues all collapsing back can close that airway off and reduce our oxygenation. And one of the ways it may manifest is through reverberation as you're trying to breathe. And that reverberation could be snoring. When we don't have enough oxygen supply, it will lead to what we call hypoxia. Okay, so lowered oxygen levels. And one of the things that our brain will do is try and wake us up and get us to take a deep breath, to gasp, to get oxygen back in. So we'll disturb our sleep, and therefore we're going to have poor sleep quality. This is why we might see patients who complain of non-restorative sleep, maybe waking up in the night, feeling, inattentive at work, tired at work, tired while they're driving, falling asleep easily during the day. These are different presentations we may see, and things that should red flag and make us think about this stuff. Okay. And how do we measure it? Well, we measure it using the apnea hypopnea index, okay, or the AHI. So you'll hear this term quite commonly, and you're going to hear it through the course of this webinar. And what we're talking about basically is how many events are they having during the course of their sleep. And we're going to talk about this and what it means and what we're trying to look at and the relevance to us. So is it a big issue, I suppose, of what you're wondering? Well, it really is, with 1 billion people globally believed to be affected. So if there are that many people who are affected by it, let's say, for example, there's 6 billion people in the world, and we're saying 1 in 6 people are going to be affected by it. Are we doing a good enough job as dentists of diagnosing this? Because it's clearly extremely prevalent in our populations. And you know straight away whether we're diagnosing it or not, because how many mandibular advancement devices are you, or CPAP device or sleep studies are you referring for or doing in-house? And the chances are, if you're not doing that many, or is once in a blue moon, maybe once a year or less, the reality is we are severely underrepresenting ourselves as clinicians and not diagnosing this potentially serious issue and disorder. So this is strongly linked to cardiovascular disease, metabolic disease, and cognitive decline, and has many larger impacts on us. So what can we do? Well, one of the things we probably need to think about is screening our patients for sleep apnea. And the reality is you're probably doing all of this in clinic already. I suspect many of you probably have some form of screen in your medical questionnaires. But the question is, are you doing it? Are you performing it? Are you acting on the responses that you're getting? It was really interesting. I may speak about this a little bit later, but Dr. Damien Teo did a presentation, a webinar fairly recently, I think a few weeks ago. And it was interesting that he was talking about it being, I think, a bit like periodontal disease, is the example he gave. And I thought it was a really profound, really good example, because one of the things he mentioned was like, you don't when we are looking at patients during examination, we're checking their CPIT and we're screening them for gum disease. And we tend to get on it pretty quickly. The minute someone has a CPITN of 3, we tend to jump on it like anything. Improve your flossing, do a clean, maybe do depending on how many CPITNs of 3 there are, we will do pocket probing, and we'll do a 6-point pocket chart. And then we'll do some root surface debridement, possibly we'll just do a detailed clean and then review in 3 months or 6 months or whatever your protocols, whichever protocol you're choosing to follow. But you'll get on it pretty much straight away. If you see an early enamel lesion in a bite wing radiograph, you're going to tell the patient you're in E1, E2 lesion, outer 50%, inner 50%, or then D1, 2, 3, outer, middle, inner third dentine. And then what their risk is and when do I not need a filling. E1 or E2 enamel lesions, you'll say, you don't need a filling, we can monitor it, floss, fluoride, get on top of it, potentially reversible. Even a D1 small lesion, 65% won't be cavitated. And you'll say, hey, we should monitor it, but you're proactive about doing things, about getting on top of it, getting on top of dietary care, hygiene, everything. But here's the thing, a patient comes in and says they're snoring on their medical questionnaire. And what's the response of most dentists? Scarily, it's just like, we've looked at their medical history. And that's scary. We wait for them to get profound sleep apnea or come in with serious issues as a result of their sleep apnea before we even think about acting on it. Why are we waiting for it to become a severe problem when we consider that it's potentially a spectrum, something that can lead to other illnesses and worsening of health? Why do we wait before we act on it? I think this is a really important thing that we need to consider. This is a really important, really good way of looking at it. So we've got to really consider our role in this. But why a dentist? Well, we're probably amongst the best people to do this. Now, patients will go to their GPs when there's a problem or when there's a significant health issue, normally systemic health problem or something that's happening. Maybe they're like not sleeping well. Maybe they are tired during the day. Maybe there is a cardiovascular health issue that's occurred, as part of this. But these are all late things. However, we're seeing patients every 6 months or so in general, in the main, maybe every year, if they're really good with their oral hygiene, oral health. But we're seeing patients once or twice a year on the regular. I don't know about you, but I don't really regularly see a GP. I never see a GP anywhere near as frequently as I would see a dentist. And that is, I'm not talking about me seeing my colleagues either. That doesn't count. But what I'm saying is we're more likely to see a dentist. So you're more likely to pick up on issues early than another health professional. We're also frequently looking inside their mouth where there'll be lots of clues going on that will tell us what's going on. So we have a really key role. And our role is really identifying, signs and symptoms, stigmata of, sleep apnea, parafunctional habits that make us think, is there a problem going on? Is it just parafunctional habits? Is it daytime clenching? Is it grinding? And, do they need, something for sleep apnea, like a mandibular advancement device or, a CPAP device? Or do they simply need a splint because it's just simple parafunction? Does anyone know what the issue is? And this is something I'd actually probably like to, I think it's a really important question to ask you all. Your patient comes in and they've got signs of some tooth wear. Maybe they've got some scalping their lateral tongue. And I see it quite a lot where a dentist will turn around and say, oh, you're grinding your teeth. Cool. And then they'll sometimes get a splint made. But what's the problem with this scenario? You guys just go to the chat box And in the chat box, I just want anyone or everyone, just type something. Time just to wake ourselves up, but let's do something. What's the problem with giving a potential sleep apnea patient a standard splint? Does anyone have any idea? Waiting to see who's going to get involved. Who's going to be brave enough to put something down? No one. Everyone wants to stay silent. Does anyone not think they know the issue with this? If you don't think you know what the problem is with this, just put N and click N. It also helps me it helps let me know if you're awake or not, or if you're actually watching this. Anyone, any ideas? Or no ideas?
It looks like chat's disabled.
Oh, is chat disabled? Is that why? I thought it's being lonely. That might be why. Okay.
We've
I've
got
got no idea how to turn it on.
it's in the Q&A. In the Q&A.
Oh, here we go. 1 second. Oh, I don't have an option to turn it on. Oh, Q&A. Here we go. Oh, here we go. Q&A. There we go. Increase oversight. Oh, there we go. Thanks, guys. Not alone. Chatbot table. Oh, thanks you. Okay. So cool. Do you know what? A couple of you guys have answered this, which is great in the Q&A. Thank you. And thanks for letting us know the chat was disabled. Do apologize. But you guys have got it right, those who've answered. You have come down with the fact that, that actually it moves the jaw back and it worsens your sleep apnea. So I hope everyone understands that. That basically what happens is when you make a classic occlusal splint, you normally look at your teeth in intercuspation, in maximum intercuspation. And so what will happen is your lower jaw is held back. And so you're actually holding your jaw in a retruded position. Now, let's think about it. We've all done, basic life care, basic life support. Okay, probably as part of our training, as part of our CPD, or you've done surf lifesavers or something. When a patient is passed out and they're unconscious, what happens? Their airway obtumbs. Okay, so often what you do is you get them to lie on their side, you put them in the recovery position, and as you go into more advanced life support modalities, you'll start doing a jaw thrust, or you may do a jaw thrust, and that's what a mandibular advancement device is doing: is bringing their jaw forward to open up their airway, lift the floppy tissues away, and open that airway and allow the introduction of oxygen in. So yeah, we don't want to be making guys who've sleep apnea a classic splint. And there's sometimes I've had patients who are likely to have sleep apnea. They come in, they go, oh, I just want to get another one of these made. And they're just waving their maxillary splint. And it's like, oh, that's not actually what you need. Or even worse, sometimes they tell you they've got sleep apnea and they've got kind of a new splint made. And then you think they need mandibular advancement device, but they bring in an actual maxillary splint. And they're not using a CPAP either. And that can be quite concerning. So the goal we have in clinic is to identify patients who may benefit from sleep testing. And how can we do this? Well, as I said, many of you are probably already doing it. Many of you are probably already asking your medical histories, do you snore? And that's a classic starter point. And I think that's a starting point for many people, or does your partner complain that you are snoring? These things can be very, very quickly picked up in your medical history. You could also have questions in there such as, do you feel, adequately? Do you feel that your sleep is restorative, or do you feel tired in the morning after you've slept? Do you feel tired during the day or unable to concentrate? These are things that you could put in your medical histories, or you can use them as further exploratory questions. You can also put questions that go around observation in terms of, have you been observed to, stop breathing during sleep or take big gasps, breath? these are also things that, sometimes patients say, I don't snore, but my partner thinks I do snore, or my family says I snore, but I don't think I snore. And these are often red flags and warnings and things as well. These will help us identify a patient. And we can explore this further with conversation during the consult. Once we identify a patient, we then want to also consider prompting a patient to discuss this with us. We don't want to be, when a patient comes into the room, we don't want to be the one that's telling them that there's a problem, that you have to do something. Sometimes patients get on the defensive very quickly. And for them, it feels like we're trying to upsell them something, another product, another toy that they don't want, or they don't need, or they won't use. So I was always told you can't treat a patient who's not dentally aware. So your patient's got to be dentally aware. So what does that mean? It means they've got to understand that there's a problem. And once they understand there's a problem, they start to seek a solution from you. They start asking you for a solution. It's very different from trying to tell someone they need something they don't perceive an issue to exist. So one of the ways we can do this is by placing flyers, posters, and information around the practice. If you've got screens in the practice in the waiting room, you can run videos that just talk about things like sleep apnea, or even pose the question, are you sleeping well? Do you feel tired after your sleep? Are you feeling tired during the day? Do you feel able to concentrate at work? Are you, do you feel tired when you're behind the wheel in the morning? I mean, because those would all be concerning features that would suggest maybe there is a sleep issue going on. We can educate our admin staff at the practice, the front desk, to start prompting the conversation. So if a patient does put in these red flag things up, that we do say to them, hey, you should talk to Dr. Rohit, Dr. Jane, Dr. Sue, Dr. Helen, Dr. Hugh, about these problems in your consult. We should really target this. And once we see that these issues are going, we should think about scoring systems and screening systems that will evaluate what is their risk for having these problems. Do we need to think about some form of testing to work out what's going on? And this is, well, we'll go into that in a second, actually. Sorry. One of the most common things I would say is if a patient says they're snoring, and this is something I used to get a lot of in the clinic when I was in a busy corporate dental practice. I used to have a lot of patients coming going, hey, I'm snoring. Could you make me one of those devices for it? But as you well know, within Australia, we can't just make a mandibular advancement device without an appropriate sleep study and a sleep physician report with a diagnosis. So what would happen is we'd end up in this rigmarole. And this is what really put me off sleep in my journey when I started. Because a patient would present with a problem, then I would say, well, I'm going to refer you to GP. And then your GP is going to refer you to a sleep physician. And then your sleep physician is going to get you to have a test done. I don't know what it will cost. I don't know what the rebate will be with Medicare, how much it will be or not be. Once you get the test done, you may be offered a CPAP mask or a trial of a mandibular advancement device, at which point, will that patient come back to me or not? I don't know. Will that patient actually see the whole process through? I don't know. There are so many hurdles in that pathway that what I would often see what I would often see in my practice is that these patients would be like, that's too hard. And they go in that too hard category and nothing would progress. And if nothing's progressing, it means things are getting worse in the background. So we're not dealing with the problem at hand. So we had to have a better way of dealing with this. How do we deal with this in real life? So the first thing we would do is obviously when a patient comes in, they complain a bit, we look in their mouth and we try and look for stigmata of these kind of issues. So what would that look like? Well, we look for signs of bruxism and parafunction, stigmata of parafunction. So we'd see things like scalloped tongue, for example. We may see worn teeth. We might see linea alba in the buccal mucosa, signs that they're catching their cheeks. Narrow arches, class 2 retrognathia. Maybe they're like me, got a big beard and they're covering things up. Find out if I'm actually class 3, but there we go. maybe we see like a large neck circumference, high BMI, overweight, and maybe they're complaining of snoring or non-restorative sleep. These are things we can talk about and look at in the mouth when we see our patients. If we have red flags or things that cause us concern, a great thing to do then do a stop bang test. And that is, even if you think there's a parafunctional habit, it's probably worthwhile doing a stop bang test questionnaire just to evaluate what their risk of sleep apnea is. And this can easily be done in the clinic simply by asking them about snoring habits. Are they snoring loudly? Can it be heard through closed doors, or do their partner or family members or people in the house, housemates, complain of their snoring or hear them snoring? As we said, talk about tiredness, and it's not just saying like, do you feel tired? But some people go like, I feel all right in the morning, but then they realize it's only when they get in the car and start driving, they're falling asleep and maybe while behind the wheel, which can be very dangerous to them as well as people around them. Or at work, inability to concentrate at work sometimes can be one of the signs of tiredness and not sleeping well. As well as we ask about, has it been observed they stop breathing or choking or gasping during sleep? And sometimes people's partners will say, oh, actually, they have said to me, I don't believe it. My partner's told me this. And then we can also find out, have they ever been treated for high blood pressure? And that's the STOP criteria, STOP, snoring, tiredness, observations, pressure. The BANG relates to body mass index, so BMI. So all we need is a height and a weight, and we can calculate their BMI. Many people will know their average weight, what they tend to be around, and they've got a fair idea of height. Maybe if you're in a clinic that does a lot of this or sees a lot of patients with this, you could just have a set of weighing scales and a measuring tape from Bunnings to easily measure them. We ask them about age. Are they older than 50? Their neck size. Most gentlemen will know their collar size. If not, a measuring tape around the Adam's apple will suffice. And are you male? Now, the risk of the stop bang questionnaire, of course, is you will probably be overly sensitive and tend towards men over 50. It's the nature of the beast, but they're also the higher risk people as well. So obviously for patients low risk, 0 to 2, they probably maybe have a parafunctional habit, maybe just a splinter will suffice. However, if they're answering yes to 3 to 4 questions, or they're answering 2 or more in the stop area, and they're male, we consider them an intermediate risk, and it may be worth considering whether we give them, provide them with the option of testing to see if they've got elements of sleep apnea. Obviously, they're high risk. We've got to consider, more seriously what's going on here. Why is this happening? What's going on, and what the impact this will have on them. And this is where patient education is key, helping them to understand the risks associated with this or ignoring it, because often that's what happens. This gets ignored till it becomes a bigger problem later on. There's more profound health issues that are occurring. Other tests, which are not, in my opinion, as sensitive, are things like the Epworth score, and this is mainly looking at rates of daytime sleepiness. There's a bunch of questions, and you're ranking them 0 to 3, basically on like no chance, slight chance, moderate chance, and high chance. And it's a series of questions. And any score greater than 10 suggests a significant risk. And this might be a score that you use to justify sleep testing. So it could be just a case of providing your patients with a simple questionnaire that they can do if they raise any red flags. And this is something that some clinics will choose to do. Stop bang has been something that I've tended to do in practice, but it's not, but not so much the Epworth, if I'm being completely honest with you. Another test that exists is the OSA 50. And if I'm being honest with you, this is not a test that I ever done, really, as such in its formality. as it's here, but there are elements of this that are obviously incorporated well into the stop bang criteria. But it combines BMI, age, neck, and snoring, and it's used as a predictive model, and it's often used for triaging patients. So we've seen our patient. Our patient may have complained of snoring, say that they want, to treat their snoring. Or there may be a patient who has highlighted that they snore, we see signs of parafunction, or we just see signs, or they've not complained of anything in their medical questionnaire, but we've seen signs of parafunction and wear, or red flags, in their anatomy and their skeletal formation, being particularly class 2 or overweight, so forth, that make us concerned. Maybe they're readily falling asleep in the chair and it's first thing in the morning. We're like, why is this happening? So there are things that are going on that are raising our concerns. We do the stop bang, which is what I would do, and we stratify their risk. And once we've stratified their risk, we need to start having the conversation. And so that conversation should look along the lines of, how often are you waking up tired? Are you aware of grinding your teeth? Does your jaw feel tight? All those questions that you probably already do, many of which you already do in clinic. And then we start educating the patients on what our concerns are. So why we ask these questions, and then that probably piques their interest. Why are you asking me all these questions? And then we get into it. Like, actually, I'm concerned that you're not sleeping well. And the reason is that you're not breathing at night well. You're under oxygenating yourself. And these are the risks. And this is the sequelae and what may happen as a result. What can I do, doc? Well, that's when we start talking about how we can start testing and what we can do. And this was one of the biggest pain points when I started this journey. One of the biggest pain points for me was losing patients in the rigmarole of trying to get them tested, to see where they fall, which camp they fall into, because, as I said, there were so many barriers and so many hurdles your patients had to get through before you could make them a device. And you can imagine if someone's just snoring but doesn't have any other issues, are they going to want to go through the rigmarole of maybe appointment with the GP, get a referral to a sleep physician, see a sleep physician, get a polysomnography in hospital arranged to do that test, and then get the results back, and then get offered a device, or whether it be CPAP or a mandibular advancement device, etc. And are they even come back to you to be involved in this care at all? It got so hard. So often I find patients just fell off a cliff and just let it go because they got put in the too hard category. And so what's good is having options. So the question is, what can we do? Well, if our patient's presented with, like, say, bruxism, for example, or snoring, and we've done a stop bang score, and let's say it's come back as 4, what we could do is simply offer them a test to take it home. And we can stop, and we stop these in the clinic, the good sleep test. And quite simply, it's like a wristwatch and a finger probe. Very, very easy. And they just wear it overnight. So you can either sell them the device, or they can rent the device or just take it home to get tested. And they can wear it. They can get a few nights sleep with it. And then we can get it assessed by a sleep physician, which is fantastic and exactly what we need. The goal is to basically confirm a diagnosis and the severity. And so we can do this via polysomnography, sleep studies, or home sleep apnea testing. Now, the PSG is without a doubt the gold standard, and we mustn't downplay its value. But where its value lies is in assessing the central apneas. And where that lies is then, trying to make sure that we're not trying to treat an apnea that's non-obstructive with a device that's aimed at obstructive sleep apnea. So it's trying to get a correct diagnosis. Not everyone needs this, but it is the gold standard. Okay. But it may be the end point. It may be doing a simple home sleep apnea test to evaluate them and see if they need a higher test, or just to give us an initial, diagnosis, maybe initially to get the patient to understand where they're at and what's going on, and actually coach them into this journey. The great thing about this is it's an easy pathway going down the home sleep testing. So as we mentioned, a PSG is performed in lab and there's full EEG monitoring, okay? It is the gold standard. But we've got to remember it's expensive and less accessible. So for those of you, for example, who are in Australia, you may understand that when you've tried to get patients to go via their GP to a sleep physician to get these things done, it's never that easy. It's often a bit of a rigmarole. And we often lose patients who don't follow through, and that can be difficult, especially if you've got legitimate concerns. But the fact is also that the patient who's got very simple issues, or very mild sleep apneas or snoring alone, it's a very expensive, long, difficult process to go down. So do they need this full whack? And that's the problem. In other countries, you may face other issues, and you may not even have access to proper sleep clinics where you are, and that can be a different issue altogether. So obviously, different regions, different countries will face different challenges. The great thing about something as simple as a home test is that we can administer them in the clinic. We can give them to a patient. We can measure airflow effort and SpO2. And the good sleep test will measure peripheral arterial tone, and it's very much a great device for uncomplicated obstructive sleep apnea. What it will do is it will give us an indication of what's going on, but it will also, what it will do is it will allow us to get a sleep report a report from a sleep physician. And this can then guide our ongoing management. So under the ADA, the Australian Dental Association coding system, one thing that we know is that if we're getting a mandibular advancement device made, we can only get it made under, if advised for by a sleep physician. So this becomes very important. We can't just provide them a sleep test to go home with and then look at the AHIs and say, hey, I think you've got this. Let's go and make you a mandibular advancement device. We do need a report from a sleep physician before we can progress. But the great thing is we can get this, but also if there are any concerns, say, for example, like profound hypoxias or anything going on, one thing is, or any suggestions that there may be something else going on, we can then use it as a platform to say, hey, look, I'm a bit concerned. There might be other things going on. Maybe you need to go one step further and have a full sleep study performed. Great, it's a platform because now that patient's on the learning journey, they start to see like, oh, actually, it's highlighted or flagged and a more serious concern might be happening. They're going to be more likely to follow through now because now they're invested a little bit, they're invested a little bit more at each step of the way. And that becomes really important. But when it then comes back and it's something very simple or mild, or just snoring issue that's uncomplicated or uncomplicated mild sleep apnea, it means we can just go ahead and it's been diagnosed and we've got a report back from the sleep physician. We can then proceed down to actually offering them some meaningful solutions in the clinic. So we can also use the home testing kit for suspected moderate obstructive sleep apneas, as long as they've got no significant comorbidities. So the reason we could be concerned about significant comorbidities is that we are missing central related sleep apneas, so non-obstructive sleep apnea, and also something to consider patients who've got lots of medications. Let's say, for example, like lots of maybe like opiates or lots of for psychological conditions, medications. These can all have roles in providing, creating a central sleep apnea. So these are all things to consider. All patients who are profoundly overweight, that may be another indication that we may need to go down a PSG pathway. The other benefit is hope sleep testing that we can use for ongoing monitoring. Okay, and we should also consider doing one if a patient is. So many of the patients I first treated were patients who were on CPAP, but just wouldn't continue down the CPAP line. They wouldn't wear it, or they were intolerant. And this became one of the pathways to getting there, to giving them an alternate option or to trial it. And the great thing is, once we do get them onto a medically advanced device, if that is the correct pathway, we can start to monitor them and ongoing monitor them with this cool little device. And we can see if our intervention is actually having an impact, because that is also another part of what we need to do to provide this service, to make them a mandibular advancement device. One of our roles is we have to follow this up and monitor and make sure that our device is having its desired effect, and also titrate the device accordingly. So as we said, it's simply like just wearing a wristwatch and putting a finger probe on. So like many of you have probably in the hospital had a little saturation probe, and that's pretty much what it is, okay? But we get some AI reading and we get a physician's review. So a sleep physician does review this and gives us a report, which is the key to this being a useful test that we can provide in clinic. Okay, so how do we administer it in real life? Well, simply we identify and consent patients. So as we said, we identify that from the medical questionnaire, from examination histories, to talking to our patients, educating them, and making them aware. And once they're aware, we say, hey, could we please offer you this test to assess whether you benefit from managing this early to prevent other issues or to help with your sleep issues, etc. We provide them with a device we keep in house. I think it's about $119 to buy these tests. And then what you charge is up to the clinic, whether you choose a rental program where they have it for X amount of time, or you sell it to them outright to keep. Many pharmacies will do the rental, so you could actually just have a look at what pharmacies are doing if you wanted to. But you train the patient then on the device use and you sync it with the sleep care app. Okay. And then the patient can upload that data and return everything, and we can then organize for a sleep report to come back to us. When we're looking at, as a general dentist, I would not get massively into knowing all the nuances necessarily of a sleep report. I think there are important things to be aware of, like an AHI score and what it is, and understanding normal and abnormal. Normal is under 5. Ideally, you'd like to get a patient below 10. But what we're really looking for is actually having an effect. So where do they start? And after administration of the device, where are they? So we want to see improvement, and then we want to see symptomatic improvement. We mustn't lose sight of the overall picture, which is, are they symptomatically improving? Are things getting better? We can also look at things like sleep stages. So when we look at REM sleep, so we're looking at restorative and non-restorative sleep, REM and non-REM, what we're really looking for is how often are their sleep being broken up. So we need to have periods of restorative sleep for our bodies to feel refreshed, to feel awake and alert. If it's constantly broken up, this is not a good thing. So we want to see our sleep broken up less and less where possible. And that's one thing we want to see, okay? And then we'll get a recommendation as to whether a patient would benefit from a mandibular advancement device or CPAP from a sleep physician. And this is what's really important when we are going down this line, especially in Australia. We take the lead from the US on this topic. So if anyone here is from the US, like you understand that as well. So we follow a lot of the guidelines. If you look at the ADA glossary, Australian Dental Association glossary, you'll see the paper that's cited um, for understanding the current recommendations. And that paper gets revised every few years as well, so it's worth keeping an eye on. Now, as we mentioned, below 5 is normal. 5 to 15 will be considered mild. Often you're targeting below 10, but the reality is don't lose sight of where a patient starts and improvement with the device. Now, actually, we'll get to this in just a second. When you're treating with the device, the goal should always be to improve the AHIs, improve the REM sleep, and to essentially make them symptomatically better. That's what we want to see. So we want to see the patient. If the patient's complaining of snoring, we want to see that the patient says they're not snoring anymore. Fantastic. If the patient's saying they're tired, we want to make sure they're not tired anymore. So that's something that we need to be evaluating as well and not lose sight of this. But we need to make sure they're also comfortable. There's no problem. There's no point in doing this if they're going to be really uncomfortable with their jaw at maximum protrusion and their jaw feels really bad. So this is something we need to consider. So what I'm currently using as my oral appliance therapy of choice is a mandibular advancement device, but I'm using a nylon one. Now, when I first started this journey, I was using your classic acrylic devices. And one of the ways I learned about this was taking my own impressions and I gagged like crazy. So it was an awful experience. But we took impressions of the upper and lower, took the bright registration. And so I struggled with all those processes. And we took it at maximum protrusion and we'd get it set to about 60% of forward posture and we titrate accordingly. But here's the problems that I found in real life. Number one, acrylic devices are big and bulky. People who've got strong masticatory forces and those brachyfacial types with the big muscles and built up with heavy tooth wear, they do tend to break those devices, especially if you get the dorsal fin sometimes, and they break the fins off them. I found that was happening, or cracks would develop pretty quickly. They're also very big and bulky, and many patients would get the device and then just be unhappy. The amount of times I had patients who spent the money on these devices and then said they weren't using it, it was too big and bulky, and you don't know till you get it. And it's a very awkward scenario. And maybe that's more about me than it is the patient, but I felt really bad that we had a patient who bought this and it was just a glorified ornament in the top drawer of the bedside cabinet. So how can we make it so a patient is more likely to use it? So one of the things that we would do is, one of the things I decided to do a couple of years ago was to start making, get some nylon ones made, because I saw a lot about the nylon ones being thinner, durable, hard wearing, very easy, portable and comfortable. And I thought like, well, I see the advantage of a mandibular advancement device, but then seeing a nylon splint was just a magical moment when you see like how strong they are in thin section and how minimally impactful they are. I think any patient you've had who goes from an acrylic to a nylon, you ask them their opinion, it is unbelievable how much they prefer these devices in the main. But this is just my experience with my patients. One of the other reasons I get a lot of patients who may request, also one of the main reasons my patients will request a mandibular advancement device, maybe because they use CPAP at home, but they travel a lot for work, and they say, "Well, I'm not taking my CPAP with me," or I only take hand luggage, and it's just a rigmarole to carry around with it. I don't want to take it around with me, so I just want a mandibular advancement device for while I'm away on work, and that's one of the reasons sometimes we make these things because and they're ultra portable. Okay. The other thing as well is patients may also say their partner complains that the device is too loud or have to sleep in a different room. And so sometimes people want them so they can sleep in the same room as their partner. It doesn't have to always be an all or nothing scenario. It could be a case of they have a mandibular advancement device that they use every so often and they use their CPAP, or there are studies to support the use of a mandibular advancement device with a CPAP as a really good way of managing pretty severe sleep apnea. But that's a whole different topic. Okay, so nylons, they're 3D printed. Um, the great thing is there's no rods running through acrylic, no metal, no random wings or areas where you can get breakages. They're printed as one unit. The Hush Pro Vera is a FDA cleared, biocompatible, sleek, scalable device that patients really find comfortable and easy to use. And that's one of the things I do like about it. And you can, like many splints, put it in warm water and just give it some mild adjustment as well to get it comfortable. Maybe they've had a semi-recent restoration and you can, like the slightly change things, you can adapt it very mildly if there's a minimal change, or just to make it a bit more comfortable when you first fit it. It's made using a nylon polyamide 12. As we mentioned, it's biocompatible, it's BPA free, because that might be important for some of your patients, but it's also durable and stain resistant. And that's another thing that people really like about these devices. And if you if you get this Hush Pro, Vera Pro from your patients, the packet comes actually with a little cleaning foam agent as well that you can put in the container to actually keep it ultra schmick as well, which patients really appreciate. So, as we mentioned, there are many advantages to it. But as I would say to you, the reason that I started getting this for my patients and the reason why I've continued to do it, and I don't really I haven't made any acrylic ones since I've started using these, is the impact on the patient's quality of life. Often when patients are getting this, it's a large element that's quality of life related. And so if we want to offer our patients a better quality of life, we need to give them the best device that will do that. And often that, unfortunately, in my opinion, I don't think that's always an acrylic device because often the acrylic is large, it's bulky, it can be uncomfortable. As someone who personally does have a bit of doesn't really tolerate oral appliances very well, I know that having made an acrylic appliance myself, it wasn't the most comfortable or easy thing to use or wear. I just couldn't sleep wearing it. And I've tried the whole desensitizing thing and everything, but it wasn't a wonderful scenario for me. But I found that this kind of device is something that can be tolerated by the majority of people due to its lower impact. Okay, so how do we make it then? We're on that point now where we've got a sleep report and we can go ahead and start making it. Well, how do we go about this? Well, I don't know about you, but I personally scan all my patients. I do this digitally. So the way I would do it is I would take a full arch scan of the mouth, upper and lower, but you must make sure you get the gingiva. So often, when you're doing orthodontic work or you're doing making a sleep appliance, if you're making any appliance for the mouth, you really need to make sure you capture adequate amounts of gingiva. I would target a minimum of 2-3 millimeters, really, where possible. To ensure you get the best appliance possible made. Then you probably want to use something like a George gauge. And what I would do is I would measure your patient with their jaw in the normal position, sat back, and then in maximum forward. And so I do it a couple of times, back and forward, and you're looking at the difference between the furthest back and the furthest forward. And you can either, if you want to set your device, so good sleep company will say set it at 50%. So you could just measure it at 50% and lock the gauge and then take your bite registration with it at 50%. What I would say is if you want to be accurately getting the bite deviation, one of the best ways I think of doing this is actually getting a multi-bite. So I use an iTero, which you can see in this. It's not my hands doing this, it's not me scanning, but This is an iTero scanner. One of the great things about iTero scanner, I think some other scanners do this, it offers you the opportunity to do a multi-bite. So I like capturing a bite in its normal position, and then I like to do it with maximum protrusion. And then I would write to the technician and the team and say to them, these are my readings, and set the bite at 50 or 60%, depending on where you want to go. The recommendation for the Good Sleep Company is setting at 50%, and then we can titrate according to response. So if you titrate at 50% protrusion, you can then adjust 1 millimeter weekly. And what your patient can do is, with this little magical test at home, they can test themselves. What you do is you tell your patient to try and make sure they're comfortable, and you can monitor to see the effect it's having. And based on the improvement in symptoms and their comfort, you can decide where to end them. Now, there are upper um, um, two upper splints you'll get and three lower ones. So you do your upper one with lower one, lower two, and lower three. Then you have upper two, which then goes with lower one, two, and three, and each increment sets it 1 millimeter further forward than whatever you've identified as your starting position. And that, and the most important thing is, as we said, is your patient should be comfortable, but also that your patient should have an improvement in symptoms, and we monitor it initially to see that they get to a point where their AHIs are getting better. And hopefully we're also seeing improvements with their restorative sleep. Okay, so as simple as that. It's a really, really simple system. Now, just so you know, there's a dot system as well that indicates whether you are on the upper, upper one or upper two. And same with the lowers on the wing, on the dorsal wing. I don't know if I can show you that. You can see that well enough. You'll see that that's got two little divots on it. So that's number two. So this one would be a upper one, because it's one dot there. Don't see that well, with a lower two. Okay. And as we mentioned, the best thing to do is keep monitoring during this period. And this will also set reminders for your patient to make sure they're wearing it, they're using it. So we're doing everything we need to do to make sure we're staying within the regulations of managing a patient with sleep apnea, but we're also doing everything we can to ensure that our patient does wear it. They have reminders, they've been told to wear it, they're being tracked, we're logging their symptoms. And we can also facilitate how we titrate going up or down their protrusion and follow it up. We can also, as we mentioned, use it as alternative therapy. So we have failed CPAP, and for example, in a case with failed CPAP and AHI, say 18, we can try Hush Provera and retest them. And this is just a case example where someone had failed CPAP, they weren't compliant, they were struggling with it, whatever, AHIs of 18, and then we can trial them on a mandibular advancement device and retest them, and we look to see whether they symptomatically improve and whether their AHIs improve as well. And we can monitor this. It's really important to be compliant, that we do schedule follow-up. We shouldn't just be giving our patients the device and say, bye-bye, see you later. And that's where obviously making sure you appropriately bill becomes really, really important, because you need to review these patients and monitor them. But the great thing is, these are patients that you can build for life. These are patients where this encourages them to return for their checkups, their regular monitoring, and you can certainly build your practice around these kind of things. It's more reasons for them to come and be compliant and maintain their oral health and oral hygiene, and as a result, their systemic health. Okay. One of the other things that's really important to note is when we see patients with, we see more and more like kind of patients with tooth wear, and you go down the lines of, say, for example, like form out the rehabs or let's say like all on X treatments and so forth. But one of the biggest problems is that when they've got tooth wear, their lower jaw, their mandible is forward rotated. Okay, so if they think about this orthodontically or restoratively, when you wear your teeth, you forward rotate your mandible. So you go more class three. So you're going to actually improve your apnea symptoms once you actually start to restore them and open their bite or do any treatment for them. What happens is they'll go downwards and backwards. And this means that we could be making their sleep apnea worse. So sometimes we see patients who've got profound tooth wear and we haven't checked them for apneas. And what's happening is they're getting restorations, which are putting them into more class two position, which will exacerbate the apnea. And then they're getting splints made to protect the restorative work, which then hold them in a retruded position. So it's really important with these kind of patients that we make sure that we have diagnosed them correctly and give them an appropriate protective device. So sometimes their protective device for their restorative work to rebuild their mouth is actually a mandibular advancement device. So it's food for thought and something to consider. Do monitor for TMJ discomfort. Okay. Patients may find if they're too advanced for that they get discomfort. So just be aware of that. Maybe adjust and titrate. Remember, it's not about all getting to a perfect ideal AHI of below 10 or below 5 or whatever. Sometimes it's trying to meet the common sense, improve symptoms, improve AHIs, improve sleep. So it's looking at a global, bigger picture. Make sure that it is a retentive device. Just confirm that it fits well, the patient take it in and out, maybe use more water to help adjust it if required. And again, use your patient compliance tools like the app reminders and make sure your patient's using it. There's no point in going down this pathway and then not using it. So we've got to make sure everything's on top of things. Okay, cool. And that's kind of where we'd go with it. So I'd like to open it up at this point if anyone's got any questions. And then Joel, if you want to come on as well, I don't know.
Yeah, I'm happy to answer questions as well on the products. We've got something in the Q&A. Thanks, Rohit, for a comprehensive, easy to understand presentation. Just wondering if you had any experience with patients with bimax dental protrusion, anteriors extremely proclined, and increased dental side effects, e.g. tooth mobility movement with use of a MAS.
That specific scenario, no. But what I would say is, let me have a little read of that. Where is that question? Is it in the Q&As?
Q&A, yeah.
Okay. He does have an Just wondering if you have any experience with patients with bimax dental protrusion, that is extreme procline and increased dental side effects, e.g. tooth mobility movement with the use of it. So I've never had it with the use of a mandibular advancement device. That issue. The issues I used to have when I was using acrylic devices was that often patients, who were in protrusion, if we didn't make them a repositioner in the morning, what would happen is they felt their bite was changing. So they'd often end up like, moving, keeping their jaw in a forward position. And that's because their muscles have kind of adapted in that position. And so they need to be deprogrammed and get a repositioner in. And that will put them back into their normal bite. And so there are many different versions that exist. When I order my Hushed Pro Vera device, I always ask for a morning repositioner to be provided. And I give it to all my patients because sometimes if your patients are holding their jaws in an abnormal position over a long period of time, they may develop malocclusion issues. I haven't seen this happen often, but it can happen. So that's one of the reasons. Also to make them feel more comfortable during the day as well, because that could be an issue that could cause their discomfort. When it comes to bimax dental protrusion and mobility, one of the things I would say is, well, I think it's unlikely to be the device that's causing it. I would never say never, but I don't think it's going to be likely to be the device because if you think about it, the device is going to act like a retainer and add stability. So in theory, it shouldn't be doing it. So for me, the question is, why have they got a bimax protrusion? What's the diagnosis here? Like sometimes patients may have very procline, say like upper incisors, because maybe they're slightly class 3 and they've got excessive forces or tooth wear, and they're hitting their upper teeth quite hard. And so what happens is, if you've got an excessive force on teeth, there's only a few things that can happen. Tooth gets worn down, tooth breaks, or tooth moves. And so sometimes what you'll see is patients who have their teeth move and they start splaying, and they start getting, and they say, I've actually started getting gaps between my teeth, and that could be the problem. The other thing could be like things like tongue thrust and forces. Are their teeth in the neutral zone? But I think the first thing we have to start looking at those patients is their bite, their habits, soft tissue forces, how they're sleeping. All those bits have a massive, massive part to play. But I would have thought that if you're wearing any kind of splint device or retainer, that's going to inhibit tooth mobility. Now, sometimes your patients may say to you, actually, after wearing a device, oh, my teeth feel a bit mobile afterwards. But that's actually quite a normal thing after any kind of splint, because what happened is teeth do have some movement in it normally. A periodontal ligament allows for this. And so sometimes when teeth have been held, fixated overnight, and then we take them out, we do feel that they've gone from being rigidly held to having their normal amount of movement, and the patients feel like, oh, that feels a bit mobile, it feels a bit different and a bit or loose. And so that might be the mobility that they come sometimes complaining of. So the best thing to do is objectively assess this, the grade of mobility and what you're seeing, and monitor this as well over time. But I would say that, yeah, in a bimax protrusion case, I would more likely think it's either a dental issue, related to their bite, or it could be a periodontal issue. And those are things I would be more likely to look at. Of course, it could be a mixture of both, because if they've got periodontal bone loss, we're increasing the lever on the tooth. Any force in the tooth means there'll be an increased lever, which will magnify the force, and then they have more mobility, as well as their roots being less foundation, being less roots, and less bone, sorry. So I would say it's probably more likely a dental or perio issue, based on how I'm interpreting your question, but I hope that helps.
Any more
Um,
questions?
Research shows that increasing vertical can increase OSA in about 50% of cases. Okay,
I
not a
think
question so much as a statement, but
I think we
uh,
got here. Hume
I
Fleming.
think I think actually, the funny thing is, I think like Damien actually went over that in the last webinar. And so, like, what I would say to you is, Damien is a person who, Damien Teo is a dentist who is very, very knowledgeable on sleep. And if you didn't catch his webinar, I don't know if it was recorded or not, but maybe you can reach out to the Good Sleep guys and see if this is a replay or whatever, because I think he does actually go over that question, funny enough, and talks about it in a much more eloquent, knowledgeable way than I would. So I will defer to his answer for that.
Yeah, that one's on our YouTube. We can send the link through.
Great. I
Again.
think that's worth looking at.
Uh,
Have you read a case where patient's AHI, RDI, ODI has worsened with a mass device? If so, what do you think the reason for this was? Uh, you know what, Hugh? I think you might have asked that question before, actually, but I have not personally had that issue at all. Like personally, most patients, every patient I've had has predominantly had improvement in symptoms. I may not do the volume. I know, Hugh, that you do a lot in your clinic, and you probably do more of this than I do in my clinic. But I've not seen that ever happen. There are many reasons why it may happen, and I think one of the great things about having something like home testing kits is the first thing we've got to do is compliance. Because here's the great thing about removal appliance and stuff, as with anything in life, the great thing is you can take it out. The worst thing is you can take it out. And so, are they using it? Are they using it effectively? Have they titrated appropriately? And so, and I get going back to the other question, if you open someone's bite, you're moving their jaw. I think it's what David alluded to. As you open their bite, you move the jaw downwards and backwards. And here's the great thing, and here's the thing, we're making it a bit more fast too in that sense, but then the protrusion should, in theory, be trying to counteract that. So I would say the best thing you can do is monitor it. and that's what we should be doing, and seeing, what's the compliance like, what's better, and titrating it accordingly. Um, I think you'll tend to find that the vast majority, significant majority of fairness, the vast majority, that they're actually improving. But I could not probably offer you a great reason for why this may happen. And I said, I'm not personally seeing this happen in clinic.
I think we've got one more question there, Rohit.
Uh, Apart from inadequate teeth or poor perio, any other dental conditions you would hesitate for using mandibular advancement splints? I would say to you, not really, because I think because the great thing about doing a mandibular advancement splint is you're getting a sleep report beforehand. So one of the things I'd more like to hesitate making a splint, a basic splint for a patient, just like say an upper maxillary. I'm more hesitant to do that um, than a mandibular advancement device, because the great thing about a MAS is that we're getting a sleep study first. However basic or complex it is, we are getting some objective information that tells us where they're starting off at. So the classic example would be that restorative case, that tooth wear case that's overclosed. So they're more class 3, so they're compensating. But if they've got sleep apnea, we know at the end they don't need a split to protect. They need a mandibular advancement device potentially to protect them, or their restorations at the end of treatment, because they could desecrate them. So those scenarios are ones where I probably wouldn't. But of course, yes, you're right. If there are like no teeth or very few teeth, that's going to be very hard to use one, or they've got very mobile teeth, extensive perio. Um, those would be the ones where I really, I mean, I would always hope that before you made an appliance that you're not doing on someone like profound dental caries everywhere. I mean, patients should all be stabilized before any definitive kind of solution or device. So I think outside of those kind of specific scenarios, I can't think of one off the top of my head. Thanks for the question, Elizabeth.
Any other questions there? I think that might be it. Oh no, here we go.
Well, are nylon splints easy to adjust post-restorative work? So my feel free to jump in, Joel. My understanding is that you can get specific nylon polishers and polishing devices. Now, I've only been making nylon splints for about since whenever FDI was in Sydney. So I know it was like a year and a half or so. That's when I first started making nylon splints. So I think they in yeah. So as I said, you can get. I haven't had to do many. My understanding is if you do want to do them, there are ideal finishing burrs and kits that you can get out there. Or you can get a standard burr, but it's not going to be, I think, a great job if I'm honest with you.
Mm.
The other thing I'd say to you is, in my opinion, on the way the platform is, they're quite thin in areas, and that's one of the great things about nylon. So the problem then becomes that you don't want to do. So say you like did a big buccal build up on a tooth. Um, my worry for you would be then you haven't got much thickness to take away on the buccal area. If you've added a lot of restorative volume. Now, if you've tried to conform, for example, to the existing volume, say a tooth broke and you restored it, yes, I think it's quite forgiving for simple, small restorations where you're kind of conforming to the patient's existing anatomy. And
I
it's the reasons why I'd strongly recommend actually scanning all your patients and 3D printing their models if they need to fix a broken tooth.
can I add just one extra
Yeah,
bit
please.
right? Sorry. I would twofold answer that question as well, as we have a full document on adjusting the devices when they come in, which includes things like using burrs, and we have heat and a few other protocols that have been curated over a number of years and had some additions from a multitude of practitioners. But the other thing is if the restorations are significant enough, we can redo individual arches. Most of the printing and design costs are generally related to the advancement protocol, so just having the multiple arches and all of that. So we actually can remake an arch for $80. So if you've titrated the patient already and you've gotten them, presumably you would have, because you wouldn't probably be doing so much restorative work that quickly or that soon. So you'll know where they should be at. So you can just do one arch. It's only $80. And sometimes that's a quicker way to do it. And then you're going to get a perfect fit.
I think that'd be the best solution. Like I think if that's the I would say that if you do restoration, it doesn't fit, chunk it out with a burr and then just get a new lower made. If that's the only thing, then that would be a far more sensible way of doing it.
Yeah.
So you just chunk that section out, so in the short term they can still keep wearing it, and then with a burr, and in the meantime just wait for a new one to get shipped. That would be the most sensible thing.
There,
Cool, great
there
question.
are there are specific burrs for nylon as
Yeah,
well.
'cause
Um,
it does end up looking like I don't know if you've ever had a go at like trying to like you know cut nylon, but yeah, it comes out very strange when you try and take a normal burr to it. It's hard to get like a good finish as well, and like to get a decent finish on it as well. You want to have a proper kit for it. A bit like ceramic, I'd say, like you can't just take a normal burr to like say zirconia, for example. You have so many like micro abrasive surfaces that would actually end up destroying the opposing tooth. You need to have a proper like zirconia polishing kit if you're going to take a burr to zirconia. Or even if you're going to adjust Emacs and things, you need to have a proper kit for it, ideally. So I'd say the same way for nylon, if you really want to have good finishing things, just for minor adjustments, then I would say probably worthwhile is having a proper kit. Cool.
I think that was just another, sorry, quick question on stains, how to remove stains from articulating pain.
I was I've you do not pick up stage on articulate. So I've never had any stains come up. Um, what I would say the great thing is the things that like obviously over time anything white can discolor in the mouth. And so what I would say is that the great thing is in the kit. We actually sorry I don't have a picture of the kit with me. It's the most pro kit I've ever seen in my life. The first time I opened one of these, my mind was blown. It was so premium. Like I'd never seen such a premium kit like this. Because you have the two uppers and the three lowers in individual packets. The repositioner packet. There's a case. There's a cleaning solution that's got a little bit of a bleach in it as well to keep it looking schmick and white. And there was your 3D printed models as well, which you can keep or you can give to your patient. If you don't 3D print, I would really strongly recommend that you keep that. So if your patient does break a tooth or whatever, guess what? You can make a putty index. You can use it. They are great for having if you don't 3D print in house. They can really be useful to you in practice. So I would, yeah, keep those in house. If you don't 3D print, if you do 3D print, you don't have to worry because you just print out the model at any point. But that's what I would say. Um, yeah, I've not noticed any like. But the truth is, if I'm honest with you, I don't really use articulation paper on the on splints. Yes, on mandibular advancement devices, no. Because they're all going on the flat platform and being pushed further. So it's not like we're trying to give an equilibrated bite or like canine exclusion or single point contacts throughout the arch. But when I use, but I think you're probably speaking more about nylon splints, like say maxillary only. I've not noticed this. I think it's a bit harder when you use a burr, and then sometimes when you then check again, and it kind of embeds into where you've drilled the tooth, and that can sometimes be more tricky. I would just use the if you can get hold of that solution, that cleaning solution, I'll try and give that a go, or try and clean with some some solution like some orange solvent or something.
We just to answer that last question as well, Elizabeth had asked around the burrs and polishing kits. We will send through. Um, we'll follow up with a suggestion. I think we have a little pack that we suggest that's useful in that.
Cool.
Can I just add one just additional point? So Dr. Christopher Panton's just messaged me a bit of an explanation to Hugh's question as well. So just on the increase in AHI, ODI, RDI, potentially patients if they're over titrated. So perhaps even our starting position might even be too far forward. Um, Most likely lateral collapse if we're going too far forward. Um, the other thing he's mentioned is sometimes titration protocols, especially in the absence of objective data. There's actually a paper by, I don't even know how to say this guy's name, but it looks like a Dutch name. I'll send this paper through as well. Diltjens in 2015, they had a poster at World Sleep, showed a 10% of patients got worse with over titration. So also mouth opening if vertical is too great. He's from
Yeah.
Belgium.
I think that comes out of that downwards and backwards rotation of the mandible. So you remember, as you open someone, you get them more class two. That will make things worse. I think, and I think that was really useful by Chris that message, because it really highlights the importance of not over titrating at the start. I think often people think, oh, let's ramp them up into upper two and lower three. And go, oh, if you're comfortable, just go straight to the end point because you'll get the maximum benefit.
Mm.
I think that's often the wrong thing to do. I think that's why it's really important. Start upper one, lower one, and then actually monitor the effect.
Yeah,
'Cause,
and it's very easy for us to objectively titrate these days, particularly with not just our device. You might use another device, but please do use something because getting that sweet spot, it's quite easy if you start a patient not too far forward and you do have the range capability in your device that you're using. Why not get the patient more comfortable? And but a lot of the time we have a lot of data and we have a lot of objective titration data in our software. And I can tell you that almost all patients are getting to where they need to be, between that 50 and 60% of maximum protrusion. So it doesn't necessarily need to be so far forward.
yeah, exactly. I think, and then I think like on the information we've been given just now, that it clearly shows that actually, yeah, you can, as we said, over protrude them. And as I said, like I think there are a lot of people who may be guilty of that, and it's a great lesson to be learned. Start them, get them start point, and then build them up as they need it, but not lose the bigger picture of objectively where they are, but symptomatically where they are and their comfort. And that's where there is an element of artistry as well, involved. I think like not losing that bigger picture is really important. Where you want your patient to be. Oh, by the way, guys, don't forget as well that as part, under the guidance that we've got under the Australian Dental Association, we should be objectively titrating our patients and following them up with this. So if your patient does decide to not return or run away or fall off the edge of a cliff or whatever, it's really important that you document it. It's really important that you do offer your patients that follow up and that you try your best to titrate the device and follow them up as much as possible, because that is part of the expectation of providing this device. Cool.
Awesome. Thank you very much, Rohit. And obviously, if anyone has any extra questions or they think of some things later, please email us through. And you're more than welcome to schedule a call with us, any of our team at any point to discuss about product. But hopefully, you also got a lot of value out of the content in today's webinar. Rohit, sorry, you might have some other things to say.
No, look, at the end of the day, today's webinar is not so much about um, about the in-depth nitty-gritty or trying to make you a sleep physician or not sleep, but like an expert in sleep dentistry. It's about identifying it, like because a lot of our patients have got this problem. So it becomes just about identifying it. And when you get identifying it, start seeing it. it's about offering our patients some solutions or some meaningful way to find out the severity or to find a path to go down. So if we can start instituting or start them on the journey of educating them, helping them understand the relevance, helping them see value, then they're also more likely, if they need to go down that further path, that pushes them into more extensive testing and so forth, they're more likely to go on and forward with that. But we need to reduce, the hurdle, that reduce the barriers to access. And I think that's what this does, making patients aware, making patients, educating our patients on it, and offering them a way to kind of discover if there's something they can do to benefit from that, and then overall improving their health. That's the fundamental goal of all of this. Improving their health, well-being, their systemic health and stuff, and stopping them from dropping several years earlier, ideally by something as simple as getting on top of OSA. So, and also maybe saving a marriage through stopping their snoring. You never know. But thank you very much for joining us. And I'm sure the Good Sleep team will be in touch with you guys with more information.
Thank you, mate.
Too easy.